Our speaker today is David Rausch from Phoenix Controls. David is a critical environment specialist and has been with Phoenix for 14 years, involved with healthcare design and consultation for more than a decade. Excuse me. David is an active member in NFPA 45 and ASHRAE. He is an associate member of Technical Committee 9.6, Healthcare Facilities, and Technical Committee 9.11, Clean Rooms, and is a member of Technical Committee 9.10, Laboratories, and Vice-Chaired Technical Committee 2.2, Plant and Animal Environment. With that, David, please take it away.
All right, well, thanks, Dave. Much appreciated. And I also want to thank everybody out there for joining us today. I know a lot of our superiors think we don't have anything better to do than to sit in front of our screens and join webinars, but I just want to say thanks. I know that your time is busy and your time is precious to all of us. So again, much appreciated for you joining us for this this webinar. What I'd like to talk a little bit about today, we're going to talk about a number of things. With respect to healthcare and critical environments and how maybe we can approach them a little differently, especially given what we can do from a COVID-19 pandemic standpoint. Like David said, this course is an AIA certified course. So for all you engineers out there, and even if there's some IP clinicians out there as well, these can act as some continuing education credit hours for you in your pursuit for advancement. So hopefully that's helpful. Today's agenda, many of you may be aware of Phoenix Controls, but for those of you who are not, I'm just going to go a brief overview and help you understand what it is we do and why we do it. And then we're going to kind of focus in on hospital applications. Phoenix Controls, obviously, we're a critical environment focused manufacturer for Venturi valves and products, but obviously what we've seen over the past 10, 12 years is some significant performance demands within the hospital realm, right? And so we're going to cover those a little bit, again, briefly: isolation rooms, pandemic rooms, ICUs, and operating rooms. And then we'll finish it out with the design resources, because each of these topics that we're going to talk about, we're only going to be able to get a touch on each one of those. And if you want to hear more about them, we can certainly have you contact Dave and APA and get us back in front of you to dig into a little bit more detail and more meat into some of these applications. But we do have design resources, we do have support collateral available, and those will be sent to you upon request, along with some, at the end of this webinar, we'll also have some additional collateral for you as follow-up. So again, appreciate your time. So let's dig into Phoenix Controls. Like I said, many of you might be aware of us, but for those of you who don't, Phoenix Controls really is completely focused on critical environments. And we started out as a valve manufacturer for fume hood controls, where we basically contain and maintain good directional stable flow for those research spaces, right, within pharmaceuticals and higher education. Along with those controls, there was obviously a safety component to it, right? We want to be able to provide a product that allows good directional flow, safety containment for that researcher, right, and maintaining that direction. And we built and evolved off that, not only from the valve perspective, but from the controls and from the data and the visualization. Because obviously, as they get into those things, the operation and the maintenance and the management of those services and of those products is key to managing your operational costs for those high performance buildings. And then because of that safety and containment aspect to a lot of the life safety applications we get into, we provide training, right, and startup and support to our reps like APA as qualified, certified technicians to ensure that quality environment, that quality of that product is guaranteed out in the field. And so we understand many of you as consultants that are on the line today have projects that are maybe outside of the New England area. Again, we are a big family. We have around 70 plus certified Phoenix representatives around the country, and we're one big family, and we like to help each other out. And so if there's a need to support and collaborate with others, we can certainly help you do that. Just go to our website and click on the how to buy, and they'll take you right to the local representative for that territory you might be working in. And so, like I said, we are committed to critical environments. That's what we do. That's what we focus on. Anything that we do is based on customer feedback, right? So our focus is not only with our reps and with the engineers such as yourself, but also the end users, to be able to understand exactly not only how the building needs to work in order to maintain that application, but also how that building and how that space is being used, right? So that we can get you the best product and support solution available. And we've done that significantly over the last few years, especially within healthcare. And that's what we're going to talk about today. The partnerships that we've created in healthcare, not only with customers, but also with infection control consultants, really kind of gives us a deeper dive into how those spaces react and how they are used, within a critical environment and what's needed. So we're going to dig into that a little bit more. But before we get into the pandemic and the isolation spaces for hospitals, it's very clear to us, and again, collaboration with our customers, that patient experience is the key point for hospitals, right? And so quality of patient care is really their job one, and trying to maintain the quality of environment is not only the responsibility of the staff, but also obviously the building and the facility, right? And so there's two common goals here in order to maintain patient care. And patient care not only obviously reflects on infection risk and not just comfort, temperature and humidity. And so what we're seeing over the last few years is the need for multi-use capabilities, right, or room state flexibilities. And we'll dig into that a little bit more, but this is one area where I think it even becomes more apparent given the pandemic, is that many of these spaces in the hospitals are not able to be used, right, as pandemic ready because of maybe an aging infrastructure or the mechanical performance isn't quite there where it needs to be. And by using Phoenix controls and the Venturi valve, we all do give you a little bit more flexibility in order to take that room and turn it into a procedure room or create a better environment for better safety and patient care for those particular applications that are going on. It's very different how the building was being designed versus how it's being currently used today. And so there's a gap there, I think, that we can kind of help close in. Life safety is always the priority. We see that and we hear that every day here now with the COVID-19 pandemic, trying to keep staff safe, trying to keep the isolations on those patients. Again, it's the first priority of the hospital for patient care, and it's also a first priority to maintain their staff, right? And they're their most valuable asset, and they're the ones that they want to be able to protect too, especially in keeping them safe during these type of times. And then also energy. Energy is another challenge for healthcare facilities that we can help with. Hospitals consume 2.5 more times the energy than a commercial building. HVAC is pretty significant cost, 44% of the building utilities for a hospital. It's 60-70% on the research side, but still significant for these buildings that are trying to become more higher performance. Right, and so any way we can help them reduce their carbon footprint is obviously a good thing, and so we'll continue to focus on that. Now, when I talk about Phoenix controls, many of you, like I said, are familiar with the Venturi valve, right? And that's the difference between what is typically used in a hospital today is the VAV box versus the mechanical pressure independence of the Venturi valve. And not knocking the VAV box so much, it's just, I think for many of these spaces that we're seeing in healthcare, it may be a little bit misapplied, right? And so we have some data to share, to try to show you that. But let's talk about a little bit about the differences. So we all know what a VAV box is, right? It has a blade damper inside there. It has a transducer that measures the pressure in the ductwork. And by measuring that pressure in the ductwork, it finds its position in order to try to manage the airflow, right? And obviously managing airflow with temperature control as well. But over time in a hospital, especially on the exhaust side, that lint can build up on that transducer. Right, and this is what the picture you see here in the bottom left corner. Right after around 6 to 9 months in a hospital, that lint can build up on that exhaust valve and cause a drift of around 25 to 30%. And that also, with that pressure drift and also with the constant positioning and measuring, we see pressure fluctuations. Right? And pressure fluctuations at the end of the day can result in compromising the directional pressure, especially, like I said, for some of these more critical spaces like isolation rooms and so on. Now that's very different with the mechanical pressure independence of the Venturi valve. The mechanical pressure independence has a cone and funnel assembly inside the middle of that Venturi, right? And within that cone and funnel is a spring. And that spring inside there compensates for any of those fluctuations in pressure that you might see in that ductwork. And so stable directional flow takes away, that risk, right, of compromising pressure. So for any pressure fluctuation, it neutralizes that and goes straight to position, finds the flow that it's needed, and accommodates that instantly, right, with that spring. And so it doesn't matter for the Venturi valve of the lower pressure, lower flow, higher pressure, higher flow. We can maintain a high level of accuracy and dependability to maintain good directional flow during any occupancy state within that room. Again, offering that multi-use option for the hospital. And so this is what we do, right? We've been doing this for a long time. Again, this type of technology was needed on the research side, and now we're seeing that it's also needed on the healthcare side, and that's what we'll dig into. Now, to prove that, here's some data to show you a pressure trace comparison between a Venturi valve and a VAV box. Now, this was done by a third party to kind of support an understanding of environmental monitoring, right, for some of these spaces. And in order to get good environmental monitoring, they needed to have stability in order to get good data from those sensors. And so they were tracing the VAV box versus the Venturi, and you can see that the spikes in the black line there are the VAV box, and the green is the Venturi valve. And again, you can see a standard deviation of less than 0.01 for the Venturi, but you're seeing spikes of over 0.02 standard deviation for the VAV box. And again, given those pressure fluctuations and that instability can compromise flow, and it can compromise some of the sensor data that they were pulling back. And so how do hospitals deal with that? Well, sometimes the only option they have is to increase air change rates, right, or to increase flow to try to stabilize that out. And obviously with aging infrastructures and stuff, that can actually be fairly taxing, right, on an existing system. And that's really what brings us back to the question of, were we ready for this, right, as a healthcare system network in North America? We saw obviously what was happening from the transfer of the pandemic going from Asia over to North America, and how it hit us here on the East Coast, especially New York City, right? Everybody saw what was going on in New York City, and the risk that was generated. There was, at the time, I think it was, thinking back to February, mid to late February, it was pretty clear with the hospitals that we were talking with that they were really kind of looking at themselves and saying, okay, are we ready for this, right? How do we get ready for this? And they obviously had their challenges with existing infrastructure and existing mechanical systems, right? And so trying to make sure that they had enough ICU beds, pandemic ready type spaces in order to handle the demand was certainly going to be a challenge for them. And so what we wanted to talk about and introduce today is the fact that there is application, there is technology out there that can certainly put a hospital in a much better position for the next one, right? This is really kind of a never again campaign, right? Where there's technology and options available in order to accommodate this type of an outbreak. And this is something that we started to looking into even after the last SARS pandemic that came through. But we're going to talk about isolation rooms because that's what's the focus of today, right? In today's world, having an AII or an airborne infectious isolation room, the basics and the general requirements are pretty specific. And they're pretty clear, right? Per ASHRAE 170, the whole point of an isolation room is to control and minimize the spread of the infectious disease, right? And so when you have a space, in order to, again, protect the staff, protect the patient, minimize its spread from the public into the corridor, how do you accomplish that? You accomplish that by negative pressure, right? And so the criteria from CDC and ASHRAE 170 is isolation by maintaining a negative pressure, always, right? So unoccupied, you're able to turn those down with 6 air changes per hour, some of them down to 4. But those always have to be maintained in the negative direction, right? Switching pressure relationships is not permitted. A number of years ago they were, but they don't want any more entrainment or any existing or residual outbreaks, or especially if those spaces were to have been used for an immune deficient patient, right? So they don't want to be able to switch from negative to positive or positive to negative, just given the residual, right? So these isolation spaces are now, AII spaces, are now dedicated to negative pressure always. They are required, like I said, to maintain negative 0.01 inches of water column. They must be sealed pretty well. And here's a code requirement that is, I'm going to go back here, sorry. Here's a code requirement that typically gets interpreted a little bit differently, and that is the constant visual audible device, right? The monitoring the pressure differential. Now, this can be done through the BMS, but many hospital campuses are fairly large, right? And so it's more important for the staff and the people working the hospital or that space to understand that that space is pulling a negative draw always, right? So constant local monitoring pressure is certainly key for these spaces. Again, we need to maintain 12 air changes, negative direction while occupied, right? And any kind of filtration on the supply must be at least a MERV 14. It's obviously that's a minimum that can be supplied higher if needed, 17 or MERV 19 or HEPA 19. Upstream on the exhaust fan, it's recommended to have filtration as well, right? Now, in the States, isolation rooms can have ante-rooms with self-closing doors that does tend to make things a little bit more complicated, but that's something that we can certainly help with. That when you look at the diagram of an isolation room, basically what we use from a Phoenix Venturi standpoint is what we call a tracking pair. You have an exhaust valve tracking the supply for these two spaces, the ante room and the isolation patient room. And that directional pressure has to go from the public corridor through the ante room and cascade through the patient room, right? All maintaining that negative direction of at least 0.01 inches of water column. Now again, tracking pair, exhaust tracking the supply, maintaining an offset, right? So that volumetric offset typically falls between 100 to 200 CFM under the door. Again, maintaining that direction, isolating that space, isolating that patient, reducing any kind of mitigation or reducing any kind of transmission of outbreak out into the public corridor. And you have your APMs, you have your pressure ports, your room displays, again, all that visual information needed in order to make sure that it's maintaining that direction, that quality all the time, okay? Now, when you look at that room differential that we talked about earlier, this is where it becomes really important, right? There are isolation spaces out there that maintain a constant volume dedicated exhaust in one direction. That still does not negate the pressure differentials that we're seeing and the pressure trips that we're seeing, fluctuations that we're seeing in the ductwork. And again, that can compromise over time, that can compromise the quality of directional flow. And so again, I take you back to making sure that when there's outbreaks, when there's the need for these spaces for what they're originally designed for, good, stable directional flow is key, right? In order to keep the staff safe and keep it from mitigating through the public hospital, right? So also, pandemic ready rooms, right? When we had the SARS outbreak here a number of years ago, there was an application in which we were able to provide to hospitals in order for them to be able to multi-use spaces, right? And so obviously a lot of hospitals have a lot of patient rooms. They typically range from 60 to 80% of the hospital footprint. And when you have a pandemic like this, it's nice to be able to use those spaces for that pandemic, right, or for that need. And so pandemic ready rooms are able to be turned in from patient rooms, right, and maintaining a negative direction all the time, with a control sequence. And so this is an ideal application that allows the hospital to be in a much better position for these type of outbreaks. And again, not to be a Chicken Little here or anything like that, but I was reading an article the other day that stated the probability of another pandemic occurring is getting higher and higher, right? And so I think this particular pandemic with COVID-19 certainly created a higher level of awareness for us, and it's something that we really need to investigate in order to make sure that our healthcare system and our hospitals are ready for the next one. And so this is certainly an option. The pandemic ready rooms, like I said, in the event of a pandemic, we can switch those neutral pressure patient rooms into being pandemic ready, a whole suite of them. And how do we do that? Well, the first step is patient rooms are allowed to recirculate, right? They can recirculate air up to 60, 80%. The recirculation system must be turned into a 100% fresh air system by closing the return air damper. Step 2 is basically to open the exhaust damper and switch on the exhaust fan, right? So now you have a dedicated exhaust fan for that pandemic ready situation. You basically turn that on, and then at the same time, you increase the exhaust airflow. So again, for the Phoenix valve, we go to a higher position, usually around increase the airflow on the exhaust side by around 15%, and then we make sure that way we make sure that we're exhausting more air than what we're bringing in on the supply side, creating that negative direction, right? Now, the most important thing here, sorry about that. The most important thing here is to make sure that we compensate, right, for that offset air. And so once you increase your exhaust air to those spaces, we don't want to have to steal any air from any of those surrounding or adjacent spaces. So in order to accommodate that additional exhaust air, we want to bring in more supply air in the corridor, right? That's feeding those spaces. That way we don't starve the other spaces, within that zone. So again, 3 easy steps. Recirculation system is turned on to 100%, 100% fresh air system, closing the damper, right? Then we open the exhaust damper, switching on the exhaust fan, and then we increase the exhaust airflow within those spaces, and then we bring in some makeup air into the adjacent corridor, right, to compensate for that offset air. So pretty simple, right? All done within a control sequence. And so this is a diagram look as to what we were just talking about. Typically, your pressure is neutral for patient rooms, 4 air changes per hour. We were showing this diagram here with a tracking pair system, supply valve, and a JEX valve or a return or a exhaust valve. Again, exhaust tracking supply, maintaining neutral pressure, both again applying the same amount of flow into that space, right? But then when we go into pandemic mode, what we're going to do is we're going to open up the exhaust fan, turn it on, and we're going to shut off the fan to the damper to the air handling unit to stop all the recirculation, right? And then we directly pull the negative pressure, we'll pull the negative air out of those patient rooms, just like this. So again, valve shuts off to recirculating, fan opens up, we increase our exhaust air by around 15%. We ramp it up from 4 air changes to 12 air changes, provide a negative pressure, okay, all within either a scheduled type of situation or that can be initiated at the view monitor. Again, monitoring that room is really important. Again, also being able to supply some makeup air to compensate for that additional exhaust air that we're pulling out of the patient room. Okay, so that's what it would look like. Again, pretty easily done and a really nice option for hospitals to have, again, for these type of situations. Because quite frankly, when you look at the needs that we've seen through this pandemic, what we need is ICUs. What we need are spaces that we can easily turn into pandemic ready, right? And there are hospitals with rooms left over. There are hospitals with spaces, but yet the HVAC that applies to them isn't necessarily accommodating to get them in this type of position, right? So I think as we move forward, with a lot of the healthcare facilities, I think it's important that we start to look at the flexibilities, right, and the diversities that they have for these type of pandemics. So how are we helping now? like I said, anything that we just talked about between pandemic and isolation spaces, that's something that needs to, obviously it's an engineered system. It has to be designed in. That takes time, right? And obviously with COVID-19, there wasn't a lot of time to get ready, right? And so we as Phoenix, we did work through a couple of our reps with the FEMA response team and proposed, an application, if you will, along with the Army Corps of Engineers to help convert hotels into ICU-like type facilities. And so our proposal was to basically, very similar to what we talked about on the pandemic readiness, was to apply constant volume valves to the toilet exhaust, have dedicated exhaust fans on those toilet exhausts, and then provide APMs and monitors, to make sure that visually all those rooms are going in the right direction. And then obviously supply fans and supply valves to that corridor to compensate for the makeup air for that negative draw, right, that's coming out through those toilet exhausts. The benefit here is that there's limited balancing. You can get the building up and running quickly, and you can provide good, stable, dependable directional flow, right? And so that's something that we can certainly do in the short term. But like I said, for the other applications, that's a much more integrated design for the hospital. But I think you're going to see from the CARE Act that was approved through Congress, you are going to start to see some federal funding coming through for those hard hit hospitals, for those hospitals that did have resource issues in order to getting pandemic ready. And so that's an area where we can certainly help. And we do have a number of hospitals. This is an example of one of them. The University of Kentucky Medical Center is sitting pretty good right now. They've had Phoenix Controls tracking pair, the systems we just talked about, in their patient rooms, both in the exhaust and in the bathrooms, the acute isolation rooms, ICUs, burn units, emergency exam rooms, operating rooms. All of those spaces are considered critical care spaces and need to maintain a good directional stable flow in order to maintain a healthy environmental quality, in order to reduce the inpatient risk, but also to maintain a flexibility for the hospital to accommodate situations like this, right? And so it does exist. They are out there, and we've had some good success with them. Now, I want to step back a minute here and talk about what you heard me say term as environmental quality, right? There's a number of healthcare organizations within this industry that are really starting to focus in on environmental quality and what its impact is on the infection risk. Now, so isolation and pandemic aside now, environment and how the building reacts or how the building accommodates the use of that space is certainly being looked at. We've seen, just from an ASHRAE perspective, we've seen the number of pressurized spaces increase from 70 some spaces up to 144 plus spaces. And when I talk about critical care spaces, I'm talking not just necessarily about what goes on with the patient, but just the need for pressurized space, in order to manage particulate or quality of air, but also just the air change rates, right? If you have a higher than normal air change rates, anything above 4 or 6, there's something going on in that space that's critical or that impacts the effect on the patient and the safety of that staff, right? And so these are a number of different spaces that are being looked at, and some that you may not have heard of, right? I mean, obviously laundry areas, hazardous waste areas, NICUs, ICUs, even emergency departments right now are being looked at to maintain a better directional flow in order to keep that space cleaner to reduce their infection risk. And this is something I feel that we as the US are a little behind on. If you look at Canadian standards, there's a lot more pressure requirement spaces, higher air change rates. Even over in Europe, the pressure requirements are more stringent, and the higher air change rates are there. And again, all of it is because it goes back to infection management. Better quality, better environmental quality reduces your infection risk is basically what we're seeing. And that takes me back to infection management, right? Like I said, this was something that was being investigated prior to COVID-19. When you look at infection impact on hospitals, here's some numbers from the CDC. Hospitals require HAIs, 1 in 25 chance of receiving an HAI. The extended stays increase from 3 to 4 days up to 10 additional days on average if you receive a surgical site infection. The ranges of the cost per infection are varied. Obviously, a MRSA event versus a C. diff might be, significantly different as far as costs go. However, on average per CDC, the average infection rate is around 35,000 per infection. And so there's a number of them, and there's a number of control measures being put on them, and there's a number of quality processes and audits that are being put on those. But how we as a critical environment provider, how can we help, right? Well, like I said, we've partnered with some infection control consultants to try to understand a more holistic, comprehensive approach as to how these environmental parameters affect the impact of infection on patients and in these spaces. And quite frankly, it starts off with the people. Now, obviously, we need people, we need the staff. They're there for a reason, right? But as soon as you have an OR that goes from empty to now active, that increases your particulate count per an ISO class type standard from 500,000 parts per million to 5 billion parts per million, right? And we as people, obviously, we shed skin bacteria up to 1,000 to 10,000 skin cells per person per minute, depending on, the dryness or the season. And so these infection control consultants basically correlated that particulate count, right, to a proportional or CFU, right, colony forming unit. So that is what basically from in their world identifies how your infection risk goes up. The higher the number of people, the higher your CFU count, the more higher your probability of is receiving an infection or distributing an infection. Now, what else affects that? It's not just particulate counts, it's not just VOCs, but it's also pressure. It's also pressure. It's also activity. One of the areas that we tend to monitor and look at is just the OR suite itself over the patient bed, right? You have a clean air curtain that comes down over the patient in order to create this sterile field, right? But a source of turbulence for that is the overhead lights. Sometimes the overhead lights are positioned such that that sterile field is impacted. That can also increase your infection risk, right, for the patient. The other part is door openings. We talked about how important pressure is for that space. And when you open the door to that OR, you compromise the directional pressure of that space, right? And on average per CDC, that door can open 6 times every 10 minutes. So again, that's an area where if it's not made visible, maybe that behavior is not understood, right? So again, our biggest defense against maintaining good, infection management from an environmental quality standpoint is around those air change rates and around those directional pressure. But we have to understand that there's a number of parameters that can impact those. And there was another study by Dr. Farhad who said that 43% of the SSI factors are related to the environmental quality, right? So if there's ways that we can bring these a little bit more visible, then maybe we can help the hospital, reduce their infection risk, right, by bringing that to their attention. And so, like I said, at the end of the day, we're critical environment control specialists. We are not microbiologists, but we're smart enough to understand that there's a much bigger picture here, right? A much bigger comprehensive approach that needs to happen in order to really kind of go after, this phenomena of the infection rates. Right. And so it's not, we certainly respect and understand that hand sanitization, sterilization of equipment, mechanical washing practices, all that kind of stuff, that is still very, very important, but it's not the whole picture, right? There's other things that are impacting infection, and we feel that we've can really help make a difference here. And so, like I said, we partnered with the right people. Some of these names you may have seen in the past. Many of them are distinguished ASHRAE lecturers. Damon Greeley, Dr. Wagner, who's the microbiologist, and Dr. Stephanie Taylor, who's a resident surgeon here in the New England area, who's obviously one of the bigger experts, especially on humidity and its benefits with reducing infection risk. She spoke, all three of them spoke this winter in Orlando on how the environment can affect the infection risk of a hospital. So I encourage all of you guys to take a look at that seminar. It was seminar number 21 on a Sunday. if you're looking it up. But we met them through a study that they wanted to do, and we can dig into this a little bit more on a separate webinar or offline if any of you are interested. But basically, what we found is that given the different technologies that are out there and how ICUs are currently being used, is there a way to create a more conducive environment for the patient that will help reduce the infection risk? And so it's pretty clear that ICUs are very active. They have a number of different code blue conditions. They have a lot of perioperative work. They have a lot of bedside procedures. And those type of activities that go on in those spaces really require a different demand on the HVAC. Per code, ASHRAE 170, a ICU space is no different than an patient room. The only difference is the equipment, really, that's being brought in. It's a neutral pressure, 6 air changes per hour. And so with the type of activities that go on in that space, it's a high probability that an infection risk could happen in those spaces. And so this study, which I'm showing you here, this is one of the documents that we'll share with you after the webinar. It's analyzing the ICU patient room environmental quality, and it was in the Health and Environmental Research and Design Journal, peer-reviewed study. Really had some interesting results. I'm just going to go through one of them quickly, but basically what the consultant did is they wanted to say, okay, if we were to actually provide a OR-like room when needed, would that help with the ICU? Would that help reduce infection risk, right? What's the efficacy of the two different types of mechanical systems that are used in this space in order to understand the quality of the environment, right? And so basically it was head-to-head VAV box versus Venturi valve in this space, along with the proposal of let's go from unoccupied, occupied to procedure mode, right? And like I said in the past, a number of these spaces, if you want to maintain good directional flow, a lot of times what the hospitals will have to do is increase their air change rates, right, in order to maintain direction. Well, that's not an option necessarily for most ICUs, right? And so the proposal is, what if we were able to change room states, on demand? So again, if a code blue situation was to occur, we can take it from a 6 air change neutral pressure to a 15 air change positive pressure, within seconds. And how is the stability, right, react, or how does that stability responsible for the quality effectiveness of that space? And so, like I said, they had a number of different instruments in there in order to measure particulate counts, but also measuring mold spores. They did a number of different gases and particulate expellents in that space to represent viruses and bacteria, and the results were quite interesting. This is a room comparison, again, of a VAV box over a Venturi valve, and what I wanted you to notice is that during the low air changes, during the unoccupied times, those are the areas in which the cleanliness of the space was significantly different, right? With the Venturi valve, we had a 65% difference in quality, better quality of that space, cleanliness of that space versus the VAV box. Okay, so again, at the lower air change, lower pressures, we had a better quality. Venturi had a better efficacy, if you will. Less parts per million. And they used sulfur hexafluoride. Sulfur hexafluoride is a small gas particle, represents a virus as a model. And it just showed how much cleaner a space can be with the right technology. And again, what does that do for the patient well care? What does that do for the hospital? It basically allows them to reduce their infection risk, right, as they treat the patient. So if a code blue situation was to happen, again, from a nurse's station, from a tablet, you can increase the air change rates immediately and get that space cleaned, right? But you have the flexibility now within the system to go from 3 to 15, again, stable transition without compromising directional flow, right? So there's a number of benefits with that. And again, that paper covers a lot of that, but they even saw reduced CFUs around the patient bed. They saw better stable transition times. Again, everything that affects the environmental quality of that space. And so that got us thinking, what can we do more to try and help our hospital customers and build a better healthcare system, right, for them based on environment, right? Because again, I think we've seen quite a change in how medicine's being delivered, how patients are being taken care of, but we've seen some deficiencies, if you will, in the mechanicals in order to accommodate that growing demand. And so what we developed and what we piloted now is a surveillance solution. It's basically a environmental quality system in which we monitor a number of different environmental parameters. And by monitoring those parameters, we can correlate that back to a microbial load. And that microbial load tells the hospital whether or not the probability of infection risk is high or whether it's low, right? But all that data that we're trending through this sensor suite, we can actually provide to the hospital to do a root cause analysis, provide quality of care information, changing their sequences, and have a better picture or an informed picture to reduce their risk footprint, right? And so we do that with environmental parameters, like I said. We monitor temperature, humidity, door switches, right, for activity, VOCs, velocities in the duct, particle counts, pressure, all those contribute to the environment quality, which also contributes to the infection risk. And basically taking all that information along with the consultants, obviously consultation, they have an algorithm that correlates all that into a microbial load, providing that hospital with the risk picture, right? And it's pretty easily visually done with a dashboard. This is our Vision CE. It's basically our critical environment dashboard. Again, it's not meant to take the place of a BMS. It's meant to complement. It's an add-on to a BMS to just focus strictly in on the critical environments. And so this is just an example to show you the operating room suite for a hospital, where you see some are in green, some are yellow, some are red. That basically identifies the infection risk picture, right? So we can dig into one of those red ORs, excuse me, and understand, what's driving that risk picture higher rather than lower. And so this is just a quick view, a very comprehensive view of all the different parameters that go into managing or identifying the infection risk from an environment standpoint, right? So we've got particle counts, we've got door opening and closings, we've got air change rates, we have pressure differentials, we have TVOCs, all those metrics, if you will, to help us understand what the infection risk is for that space due to the environment and activity, right? And so in the bottom right corner, you see the dial. It's in the red, primarily because look at what's the red headings. The air change rates are too low, the particle counts are really high, how many times have the door opened, so on and so forth, right? That gives us a picture for the quality patient care people and infection preventionists to help them understand, why is it that space may not be conducive for the application that's going on. All this is good information needed in order to make a good assessment and make changes. So that's what we can do in ORs. That's what we are looking to do in ORs to try to help the hospital reduce their infection burden. We've now talked about pandemic, isolation, ICUs, and now one more, the USP 800. Now this is an application I'm not going to be able to take a lot of time at, but basically this is another area in many hospitals where they're doing compounding pharmacies for cancer treatment drugs, hazardous drugs. Again, it stresses the importance of good directional stable flow, not only in where the compounding is going on, but also from the storage. Obviously, there's been a significant amount of conflict in the past where some of the drugs that were made were, hybrids, if you will, and the quality of those drugs were not where they needed to be, right? And so directional flow helps with that, environment helps with that, plus it keeps the staff who's doing the compounding, keeps them from ingesting any of those hazardous drugs. So that's another area in which we can help. We have a lot of resources and tools for that specific space. We can certainly dive deeper into that at another time. But at the end of the day, what's very, very important for the hospital, not only to keep their quality and patient care high, but to prove that they can with the audits, right, with the Joint Commission. The Joint Commission is such a significant organization for these hospitals. Not only does it provide an accreditation and a rating, for patients to understand the rating of the hospital, but it also contributes to their federal funding. If they get a good audit score, then they get a good amount of funding. And so Joint Commissions are focused on constant monitoring. They are focused on the environmental protection, the environmental quality of the space. They're going to want to see more information on that as time goes on, especially after this pandemic. They're going to want to see pressures, before, during, and after for these types of spaces. I think they issued a constant monitoring type of program here back in February, early February, January. And so the more reporting, the more compliance and reports and information that we can provide as control specialists is really important for these hospitals, because accreditation is very important, but it's also a significant amount of operational burden on some of these hospitals. Many of the staff have to be part of the accreditation team. They have to pull these reports together. There's ways that we can do in the advanced reporting to support these commission audits just by having these automated reports ready and available to make it easy. Because again, going back to the audit trail, if they, especially on the infection side, as they're being monitored by the government, if they are less than their average neighbor, then they are going to receive reduced funding. So it's important for them to keep their infection rates down for a number of reasons, right? But also from a funding aspect. So that's where we can help as well. And like I said, the resources and collateral, we have plenty available on this. I encourage all of you to take a look at what we have and how we can help. This is certainly an area I think that is becoming more and more critical environments than what it was in the past. And it's something, an application where Phoenix Controls can certainly help.